kind of encouragement and are agreeing to it. Now, in today's date, corneal donation, the consent is already given and it has been organ donation situation. The person has given the consent of organ donation before that. Now, when he is ill, the relatives are not aware of that. In an hypothetical situation, I am not telling that we have faced that, but what will be the status? And if the patient is dying of an sepsis, so what will be the status? The patient has given organ donation consent beforehand with this, with that kind of initiative we are taking. So what will be the flow process in this?
I mean, even if the patient has given donation, you still ask the family, right? And we just convince the family that these were the last wishes of your person. So most of them would be executing it. Thank you very much for a wonderful session.
Thank you.
Thank you, dignitaries. Moving on to our next session for the day, how I do it. And I invite onto the stage our moderators, Dr. Raj K. Mani, Dr. Deep. Our chairpersons, Dr. Launi Goswami, Dr. Yashesh Paliwal, Dr. Vaibhav Vaishnav, Dr. Mahadev A.K. and a first speaker for the day, Dr. Bhushan Nagarkar, who will speak on the apnea test. Please.
I don't have a co-moderator. Can you come over? Ashish? I will see the join, please. Deepak, critical care. Yeah. Thank you, Sunil.
Thank you.
Good morning, everyone. First of all, I want to thank Dr. Avnish Seth sir for giving me this opportunity to present the talk. I'll be combining two talks. First is the donor selection, contraindication and maintenance. How do I do it? And I'll be also adding the apnea test into it. So moving on to the talk, let's start with the case which we had in the first month of this year. So this is a 17-year-old female with severe traumatic brain injury, was transferred from the other hospital where she was admitted 36 hours prior to the transfer to us. She was referred to us because of the management of potential organ donor, as that was a smaller setup. When she was transferred to us, she was on very high dose of noradrenaline, vasopressin, and her labs actually showed sodium of 193 on blood gas, and on formal labs the sodium was around 180. WBC count was around 23,000 and procal was around 13. So the routine management which we started on IV maintenance fluid with 5% dextrose and free water through the NG, sent the sepsis screening and kept her on broad spectrum antibiotics. We started on hormone therapy with IV methylprednisolone, that was around 15 mg per kilo for her. She was on oral levothyroxine 300 micrograms TDS, and vasopressin infusion was started for DI. After the fluid resuscitation, her noradrenaline, we were able to wean it off, and she was just on small dose of vasopressin. We kept her on lung protective ventilation, and we continued with the usual nutrition, the DVT prophylaxis, position, and all was maintained. After 24 hours of ICU admission, her sodium was around 158, polyuria had settled down, and we went for the first set of brain death testing and the apnea testing for her. So just for us to all of you to understand, so what we do is we need to have an established irreversible cause of coma first, supported radiological, that was onto the CT scan. The preconditions have to be met, which I'll discuss in the next slide, and co-founding factors has to be absent. Then we can go ahead with brain dead testing and the positive apnea test if the brainstem reflexes are absent. So what are the co-founding factors? These are the co-founding factors which should be absent. So shock or hypotension per se, we need to resuscitate patient with the fluids, start them on noradrenaline or vasopressin, and maintain the systolic blood pressure more than 100. If it is less than 90, then we cannot go ahead with the brainstem dead testing. Temperature, again, it is 32 to 36 degrees Celsius. So 32 is acceptable for brainstem death testing, but for apnea testing we need the temperature of 36 degrees Celsius. Brainstem encephalitis GBS is going to interfere with the apnea testing, so we can't do the brainstem death testing in such conditions. And we know about the drugs which affects the neurological or neuromuscular functions. We have to think about high flash things, especially if the liver and kidney function is normal, then we have to go for that time frame. Preconditions, we know that the temperature 32 to 36, acceptable metabolic parameters, sodium ranges between 120 to 160, adequate glycemic control, acid base balance, and no major endocrine derangements. So as I said, prerequisite for the apnea test is core temperature more than 36. Patient should be euvolemic. PCO2, this is an important aspect, preferably if it is more than 40 or at least around 40, it's good, so that we don't have to wait for longer time to get the PCO2 of 60, and normal PO2, so that there is no desaturations during the apnea time. Monitoring, we need pulse oximeter, ECG, and arterial line for the apnea testing. And once we disconnect the patient from the ventilator, we can provide oxygen either through oxygen insufflation catheters, through PEEP valve, TPs, Bain circuit, or CPAP, continuous pressures onto the ventilator. What we commonly use in our unit is TPs or the Bain circuit. So first thing is pre-oxygenate the patient at least for 10 to 15 minutes on 100% of oxygen. We know the physiology, denitrogenation, and gives us enough time for apnea. Second is the monitoring. So we want those ECGs, saturations, and the intra-arterial blood pressure monitoring. The chest and abdomen has to be exposed. Before disconnecting the ventilator, when we pre-oxygenate, what we usually practice is we try to keep the respiratory rate slightly lower so that our PCO2 is reaching around 40. We know that every minute will cause rise in PCO2 by 3 millimeters, so we have to wait approximately 8 to 10 minutes to reach that PCO2 of 60. After disconnecting the ventilator, we attach oxygen around 4 to 6 liters per minute and closely look for any respiratory movement, that is the excursion of the chest and abdomen. So yesterday also there was this discussion, do we need a consent for apnea test? We do not need any consent for the apnea test. And very important thought over here is, when there is a circulatory death, we don't take consent from the relatives to examine the patient to declare death. Why do we have to do it for the brain?